ASH 2015 coverage in Orlando. I'm Thomas Baldrick, joined now by Dr. Owen O'Connor from Columbia University. Thanks, sir, for taking a couple of minutes out of your busy day.
Thank you for having me.
Let's talk about this study of yours, Randomized Phase 3 in patients with relapsed refractory peripheral T-cell lymphoma. And you used Alisertib for this. Why would that be?
Well, Alisertib is an Aurora A kinase inhibitor. There was some early phase 2 data in all patients with non-Hodgkin's lymphoma conducted by Jonathan Freeberg. And in that study, he noticed a pretty interesting response rate in patients with aggressive lymphomas, but in particular, patients with relapsed refractory peripheral T-cell lymphoma seem to have a response a little bit higher than the other patients with B-cell malignancies. That observation actually compelled Millennium to conduct a large randomized study to sort of cut to the chase quick to see if Alisertib would have a benefit, clinical benefit in patients that would be superior to some of the commonly accepted standards in the field.
How did you go about doing it? What was the design?
Well, the design was a randomized phase 3 study using Alisertib at its prescribed phase 2 dose, and it compared to Investigator's choice, which included 3 drugs, pralatrexate, romidepsin, both of which carry approvals in the U.S. for patients with relapsed PTCL, and gemcitabine, a drug commonly considered to be a community standard. And it used a statistical design where there were 2 interim analyses built in. The first based on overall response rate. The endpoints of the study were designed to look at overall response rate, about a 25% improvement, and progression-free survival to look at about a 37% increase in progression-free survival. So the study met its first interim analysis. It wasn't designated as futile by the Data Safety Committee, and it accrued to a total of about 270 patients. But at the second interim analysis, the statistical design was such that the conditional power of the study had suggested that the data at that time point was unlikely to meet the 33% improvement in progression-free survival at the final analysis. And so the study was terminated after the second interim analysis.
So what's significant in what you learned from that?
That's a great question. And so it might be easy for the casual observer to say, well, why would you jump from, that phase 1-2 data, small numbers, to a phase 3? Obviously, the general approach many investigators take is, well, go to a phase 2. If the phase 2 looks promising, then go to the phase 3. But I actually credit the sponsor for, taking it on. And that means that they were trying to get the drug, what they thought was going to be a very effective, valuable drug for patients with this challenging disease. We all recognize that the landscape of lymphoma has changed a lot over the last several years. We've made substantial improvements in patients with Hodgkin lymphoma, even the ABC germinal, post-germinal center large cell lymphoma, major advances. The 2 areas where we haven't done well, peripheral T-cell lymphoma, double hit lymphomas. So the notion that we could try to expedite that drug into a regulatory study, perhaps hasten its arrival in the clinic to help patients, I think is a laudable one. Subsequent data just released very recently by Paul Barr through a SWOG study demonstrated that in a population of patients with relapsed refractory PTCL, there was a very good response rate. It looked a lot like the other drugs, but this particular study revealed that it wasn't better in terms of that progression-free survival benefit. But for me, one of the interesting observations was the activity of the other drugs in the comparator arm. And while there weren't that many patients that received Romi or Gem, most of the patients had received pralatrexate. The response rate for pralatrexate was about 44%. So it actually did a little better than what we had seen in the PROPEL study, probably because that patient population was not as heavily pretreated. But gemcitabine didn't fare as well. So if Alisertib was better than any individual drug in the comparator arm, is probably a little bit better than gemcitabine, a drug for which there's really very limited published information in terms of its activity and duration of benefit in T-cell, but gemcitabine proved to be difficult to give to these particular patients. So there had really never been a large study in the order of what we've seen with BELIEF or PROPEL or romidepsin to study gemcitabine in the population. So for me, the take-home message, some of those comparator drugs, Romi, pralatrexate, performed pretty well, probably better than what the registration-directed studies did. Gemcitabine, a commonly accepted community drug, a drug used in the community for this population, didn't do as well. Alisertib probably equivalent to those other FDA-approved drugs in this setting.
Hence the term they call it trial.
Hence the trial.
And you know what, Dr. O'Connor, though, in the beginning you said the goal was cut to the chase.
Yes.
So you still were able to do that, it was just finding different answers.
That's right. Well, you know, one of the interesting follow-ons to this study could well be that some work done by my laboratory at Columbia has shown that alisertib potently synergizes with romidepsin. And that synergy we were able to demonstrate in vitro and in vivo. And now Michelle Finale at MD Anderson is doing a phase 1/2 study looking at alisertib plus romidepsin. It's very early, but her early suggestions, her early data, which I think are being presented here at ASH, seem to suggest that there's very good activity of the combination. If that holds up, if we do see good activity in the phase 2 of romidepsin plus alisertib, it's not an unreasonable suggestion to consider a randomized study of romidepsin plus alisertib versus romidepsin. That could be a regulatory study if in fact the addition of romidepsin could improve the outcome of patients with T-cell lymphoma getting romidepsin, if the addition of alisertib could help.
Very good, sir. Thank you. Thanks for sharing your time with us. We appreciate it.
Thank you.